G'day everyone, my name's Paul Martin. I am going to be talking on the basic principles or the ABCs of looking at X-rays. So a bit about me. I'm an Urgent Care Fellow and work in Anglesey Clinic in Hamilton, 24-hour clinic, where I look after the ACC injuries. I run some fracture clinics, see between 100 and 120 patients a week, looking at lots of X-rays, and did a whole bunch of orthopedics prior to this. So I've looked at a bunch of X-rays and trying to distill things to make it straightforward. So we're going to cover the basic principles of just limbs on this, and cover some common os and physes. Have a lightning quick look at just the basic principles behind fracture management. We're not going to talk about every individual fracture that can happen and all the weird and wonderful stuff. Just if you can know that it's weird and ask for help, then that's all you really need to do in urgent care. So the basic principles behind X-rays, I think about it like a light that shines from one side of the body, and you're looking at basically the outlines and the consistency of the bones. And so things like fractures are gaps and changes in shape. Thing to remember is a peripheral limb X-ray has about the same amount of radiation as being outside in summer for about 4 hours. So really, with modern imaging technology, you should have a pretty low threshold for irradiating people, as it's really not much X-rays involved. So ABC. So but they make sure it's the right patient, actually the right patient, and actually either today's X-rays or the X-rays you think you were looking at. Make sure you're looking at the right part and whether the X-ray is adequate. Does it cover enough of the region? Is it technically well done? Is the lateral and things like that? Then I advise you look around the bones, look at the alignment and the edges, and look at the texture of the bones to see if there's anything weird going on in there, and then have a look around the soft tissues to see if there's any other clues as to what's going on with signs of swelling, effusions, and foreign bodies. So we'll look at this individual's hand, and you can see that it's me, and it was taken a few years ago, but check with the date that is the one you're thinking of. So as I said before, check that it covers the area of interest. You need at least 2 views and make sure it's appropriately penetrated and technically good enough so you can actually see some reasonable amount of detail. This is an example of why 2 orthogonal views are useful. You have a normal AP ankle view, but on the lateral you can see that there is a undisplaced fracture there. Just remember that a single view can lead to misinterpretation. So on to B, go around the bone contours, and whilst it seems laborious to start with, you soon get very quick at running your eyes around the edges of every bone. And on this example X-ray, you can see if you follow every bone around, that you can see that there's an obvious crack in the ring finger metacarpal there. If you're looking at the alignment, making sure everything lines up, and again you can see that the third toe MTPJ is dislocated in this patient. Sometimes the bony alignment changes are subtle. You can see that there's a slight gap and the patella is slightly riding high here. This person's got a patellar tendon rupture, and sometimes alignment problems are quite obvious. So looking onto bony texture, then you can see that this child has got AVN of the navicular bone, and this adult has something growing in their proximal phalanx of their index finger, which could well be something like a giant cell tumour. So look for swellings. On the AP of this elbow on the left hand side of the screen. You can see that there's significant swelling there, which indicating there might be a little bit more going on there. And on the lateral you can see that there's a large anterior cell sign and a posterior fusion. Now you can get a small cell sign, probably about a third of that would be still normal. However, a posterior sign is always pathological. And knees particularly, the knee X-rays and trauma are always done with a horizontal or a ray beam and a few minutes for things to settle, and that's so you can produce what is well demonstrated here, a horizontal line. Okay, and this is showing there's a fat fluid level or a lipohematosis with this pathognomonic of a intra-articular fracture. The only other time you might see that is with a severe burns, but that's super rare. So for all intents and purposes, this is an intra-articular fracture, and so you're then beholden to find out where that is and how serious that is. So to summarize those things, learn the normal. And the other tip I have is if something's really obvious and distracting, I basically put my hand in front of it so I can look around without my eyes getting drawn there. So obviously this person's ring finger metacarpal is abnormal, but this is a congenital deformity. But it's when you see a few hands, it sticks out pretty well. And then moving on to this lady with impressive calcified uterine fibroids, really does draw your attention to the middle of the pelvis. However, if you cover that up, you will see that she's got a broken neck of femur, so probably a good one not to miss. So yeah, in summary, ABCs, this X-ray, same knee, a good example that you can see that your bony outline and bony contours are definitely abnormal. You've got a good going lipohematosis of someone with a very nasty tibial plateau fracture. So we can't really do a talk without talking about choroidal. Everybody always talks about choroidal, but no one really explains why it's important. Choroidal is the order of the ossifications, and they all are a pretty predictable age, with girls usually a little bit earlier than boys. So if you look at the numbers on the left, they're usually the signs of when these appear in girls, and when they appear in boys is on the right. Now when they fuse is slightly different and slightly variable when they're teens, and that's a lot harder to remember and is less useful. So why is this bit of knowledge important? They're also 2 years apart, so you can actually just count it up. So why is this knowledge important? Well, on this X-ray we can use exactly that. This young lady's got a sore elbow, and we can see that she's got a capitellum, and see that she's got a radial head, and we can see that she's got an internal or medial epicondyle, but she has no trochlear. So why has she got an electron growth plate? Well, she hasn't. It's a fracture. So this originally was reported as no fracture seen. But with that knowledge of the ages there, then you can see that because that order is not maintained, that this is almost certainly a fracture. So moving on to talk about some common os and physeal problems. Now, the reason I want to talk about these particular ones is these are all things that have either been phoned up about, particularly as an orthopaedic registrar, or have been sent to my fracture clinic as a fracture, or in the case of the pelvic physeal avulsions, have been missed. So worthwhile just running through these, remembering that if things are sore, then there might still be pathology there. So the os of the feet. Now there have been many os described in the literature, with a lot of these particularly rare. However, we'll talk through the 3 common ones. Os naviculara has a number of names. and they all have a range of incidence because there's been no mass population studies of them, so these are reasonably common. At least 1 in 10 patients have them. It's probably more than 20% in my experience. You can get 2 types, one close to the tibia, close to the navicular, and one a little bit further up depending on where they are within the tib post tendon, and you can see it's demonstrated just there. You can injure the synchondrosis between these and it would be a source of ongoing pain. But then this is an instance where a little bit of time and clinical examination will determine there, and then you can send them off to get specialist investigations should the pain be ongoing. Osteogonum is essentially a fibrous joint between and a bit where a growth plate didn't fuse in the posterior aspect of the talus. Now, it can cause both an acute and a chronic pain. People like ballerinas who go on tiptoes a lot can get posterior impingement, and this can cause ongoing pain, but it's not a usual cause of acute pain in an ankle. Osperineum often sent as a cuboid fracture, is reasonably common. About 1 in 8 patients from some studies, the range being quite large. Can be bipartite like the ones in the demonstration. 60% are reported to be as bilateral and often confused as a cuboid avulsion. Fibula has been a common source of phone calls as a loose body in the knee. It's a sesamoid bone on the lateral head of gastrocs, comes from the Latin term for little bean. And about 30% of us have them, of which 70% of people are bilateral. One study looked at multiple reports and epidemiological studies from through the years and determined that it's probably getting a few percent more common. So moving on to other things, proximal fifth metatarsal apophysis, early teens, usually present for between 2 and 4 years. It's usually the longitudinal part of it, so this part of it, whereas transverse ones are most likely to be fractures. However, you can damage the apophysis, I have seen that. So again, treat the patient clinically, and if in doubt, immobilize and refer to a fracture clinic for ongoing assessment. Onto the pelvic avulsions. AAS is the most common. These aren't super common injuries. You just need to be aware of them, and they're usually teenagers, usually boys, 3 to 1 preponderance to males, sprinting or kicking, sudden pain in the anterior hip. The AIS ones are from the reflected head of quadriceps, and they just do well. They need a bit of protective weight bearing, they can crack on. Moving on to the ASIS, again, a little bit less common than the AAS. Sartorius insertion, they do fine as long as they're not massively avulsed. They're more than 3 centimeters and they should probably be referred to be put back on. Again, a bit of protected weight bearing and then you're off to the races there. Ischial tuberosity avulsions are super rare, but refer these because the sciatic nerve is right next door, and if these get scarred down onto that, then that provides quite a lot of problems. Basic principles of fractures: reduce, retain, rehabilitate. There's lots of ways to hold fractures, starting with the least of a sling and a splint through cast, traction, and surgical stuff. Remember to immobilize the joint above and below the fracture. Wrists and ankles, you can get away with it due to the way of the ligaments, but if in doubt, immobilize more. And pro tips for urgent care: if it looks bent, send it to hospital. If it clinically looks like it could be broken, but the X-ray is normal to your eyes, treat it as though it's broken. Time and cast will be good, and then the people in clinic can sort that out. Kids have different fractures, more buckles and breaks, as their bones are a lot more rubbery, and the smaller people need bigger casts. So in under 2, you'd probably put an above elbow cast on rather than a below, because otherwise they'll slip off. Growth plates are also pretty challenging. Look for effusions, and if in doubt, cast and review. Here's some references, some good meta-analysis of the different things we've talked about. And any questions?